Now, which antivirals are used? Now, these are the three groups of anti-influenza drugs: neuraminidase inhibitors, oseltamivir, zanamivir, peramivir. Then a new category cap-dependent endonuclease inhibitor like baloxavir, marboxil, and adamantins like amantadine and rimetrin. Now, this is the chart taken from CDC website. These are the antiviral agents which can be used in treatment as well as chemoprophylaxis of influenza. Which are those? Oral oseltamivir, inhaled zanamivir, intravenous peramivir, and oral baloxavir. Now, these drugs have different recommendations according to age. We will go in those details in short. Now, first discussing adamantins. Adamantins are amantadine and rimetrin. The adamantins target the M2 ion channel protein of influenza virus. Therefore, these medications are inactive against influenza B virus. They are active against only influenza A. But there is widespread antiviral resistance in circulating influenza viruses. So, they are currently not recommended in the treatment of influenza. So, amantadine and rimetrin are not recommended. Now, this new drug has been come, the cap-dependent endonuclease inhibitor, oral baloxavir. It is potent selective inhibitor of cap-dependent endonuclease in PS subunit of RNA polymerase of both influenza and in B. So this drug has been approved by US FDA. It is a single dose oral treatment for individual with acute uncomplicated influenza, but it is recommended in age more than 12 years. So it has not been approved in India. So there is no point this drug we can use. Then there is peramivir. This is again new drug, intravenous peramivir, approved by FDA for the treatment of acute uncomplicated influenza within 2 days of illness, onset in people 6 months and older. It is administered intravenously. Dosing for peramivir varies according to age. 6 months through 12 years, 12 milligram per kg IV single dose. More than 13 years, 1600 milligram IV in a single dose. And its efficacy is based on clinical trial versus placebo, in which predominant influenza virus type, influenza type A, and very limited data is available with influenza B. And also there is no data available for chemoprophylaxis. And so again, this drug is not much used in India. Again, zanamivir is there. It is approved for treatment of flu in children above 7 years or older. But the problem is it is not recommended for use in children with underlying respiratory diseases, including those with asthma and other chronic lung diseases. And it has to be taken through inhalation, through a special inhaler, like a disc inhaler. So it is difficult if the child is having respiratory disease, they can take zanamivir through inhalation, and we are not sure how much drug is going. So again, this is not the first drug of choice. So what we are using or what guidelines are recommending is the use of oseltamivir. This is the class category neuraminidase inhibitor. This is most widely used and most widely abused antiviral, as I have told. So what are the guidelines? These are the Indian Academy of Pediatrics guidelines for the use of oseltamivir in prophylaxis as well as treatment. Now, the doses will differ according to the age and weight of the child. Now, the prophylaxis, to summarize this table, the prophylaxis in less than 3 months is not recommended unless situation is just critical due to limited data in this age group. So for prophylaxis in less than 3 months, there is limited data. For prophylaxis, other point is that the dose is once a day and the duration is 7 days. For treatment, the dose is twice a day and dose differs according to the age. Like in less than 3 months, 12 milligram per dose, 3 to 5 months, 20 milligram per dose, 6 to 11, 25 milligram per dose. And for children, according to weight, dose varies. But who do you need to give prophylaxis? Now they have recommendation of using prophylaxis in institutional settings, like in large, like hostels or large dormitories where the more people are living together in crowded spaces, if you have cases of influenza diagnosed in those places, then for close contacts, you can give oseltamivir prophylaxis. Also, in household close contacts, also if the person falls in high risk category, if the person is having any chronic disease, he can use oseltamivir prophylaxis for protection against the influenza infection. Now, for prophylaxis, as we said, more than 3 months of age, once a day dose for 7 days. Some guidelines extend it up to 10 days also. For treatment, as we said, oseltamivir can be used at any age, twice a day dose, and the recommended duration is 5 days. Now, adverse reactions, oseltamivir is generally well tolerated. Gastrointestinal side effects like transient nausea, vomiting is there, but it may increase with increasing doses, particularly above, up to 300 milligram. Now, we will discuss why 300 milligram, because the recommended dose is maximum 75 milligram per BD. So we will come to that point. Occasionally, it may cause bronchitis, insomnia, vertigo, abdominal pain, epistaxis, bronchitis, otitis media. So these are occasional side effects or adverse reactions associated with oseltamivir. There were other adverse reactions associated with oseltamivir in post-marketing surveillance, and there were certain controversies regarding that. We will discuss that part in later. In the setting of institutional outbreak, antiviral chemoprophylaxis should be continued for 14 days. So this is the IDSA guidelines. The IAP guidelines is 7 days, but IDSA, the Infectious Diseases Society of America, says in the setting of an institutional outbreak, antiviral prophylaxis, chemoprophylaxis can be continued for 14 days or for 7 days after the onset of symptom in the last person infected, whichever is longer. Again, as we discussed that if the antiviral treatment started within 48 hours, it gives best benefit, but IDSA and CDC, the Center for Disease Control and Infectious Disease Society of America, have clear-cut recommendations that those who onset of symptoms occurred more than 48 hours before presentation with persisting moderate to severe illness, because whenever child gets admitted for any lower respiratory tract infection in our IPD, and we suspect that this is influenza-like illness, by the day 3 or day 4, they get admitted. So in those patients also, they have shown that these patients also may benefit from the treatment. But the safety and efficacy in this population have not been evaluated prospectively, but definitely there is benefit for treating those children who presently